Hi, my name is Annie. I'm a UCLA Master's in Public Health student. I had a question for Dr. Furuhar. You had a slide before with the three elements contributing to professional wellness, and one of them was about the culture that contributes to professional wellness, and I was wondering if you could elaborate a little bit more on what are the important elements of the culture that contribute to professional wellness.
Sure. Thank you for coming tonight. There's a lot of different parts of what goes into the culture of wellness. In our slide, the culture of wellness was a category of what was found by Dr. Sheniko's program at Stanford. And what they found was statistically significant to make a difference was, and I kind of have to read it for you, was perceived appreciation. So we call that recognition in everyday life, right? So someone telling you did a great job, right? Or you did well for this patient. The fact that your values align with that of the institution, so personal alignment of values, peer support, and control over schedule. Those were the factors that were actually found to be clinically, statistically significant, meaning that when all those physicians were polled, if one of those physicians actually gave a 4 instead of a 5 in one of those categories, there was something between an 18 to 190% chance increase, depending on which one we talk about, in burnout, and a significant decrease in chance of personal fulfillment. So those are the statistically important ones. But to really talk about it, in layman's terms, is recognition in feeling that your leaders believe your input in the direction of the organization is important, so leadership support, is collegiality, feeling that you have an ability to have a good relationship and communications with your partners. We talk about resilience as another factor. If we have group resilience, it's very, very beneficial. So I hope that kind of answers your question.
Hi, I'm Rachel. I'm a UCLA Master's in Nursing student. I have a question for any or all of you regarding if you have any suggestions or advice for a student who's just entering the medical field. So I'll be starting, hopefully, to work as a nurse next year. And I'm wondering what types of things you would recommend doing in order to promote wellness and prevent these feelings of exhaustion and burnout.
Each and every day, decide however small it is, what you're going to do for self-care. I think keeping that as a focus and a priority, because it's so easy to sacrifice your own self-care for the care of others, and choose wisely. I went to an emergency department burnout conference, and I thought, oh, I'm going to learn all these good strategies, and the speaker said, make sure you pick a program where you have enough time to take care of yourself. And I thought, the answer is find something that works for you.
I would add also, in terms of finding meaning in your work, can be very protective. So I always tell our residents, when they're stuck in the rounding room and they're entering orders and they've kind of lost sight and they're getting frustrated with the medical record, to go sit with that child that they're taking care of and play cards for 5 minutes. And that can really rejuvenate you. Is that me?
I know, some feedback.
Okay. Thank you.
I would just like to piggyback on that, though. I would recommend, and hi, Rachel. I would just recommend, if anybody has that much interest in it, and to take a formal training program. The UCLA Marks Center has a 6-week program. There's mindfulness-based stress reduction. The reason being is because in crisis, we do not fall to the level of our expectation, but we fall to the level of our training. So it is very important that you get training not in crisis mode. And then when crisis happens, because statistically we know we're at risk, that way then there's something to fall onto when it happens. So there's lots of different programs, or maybe, because nursing units are always looking for unit practice councils, that's something you could pioneer as a new graduate on your unit and show leadership in, is to let's facilitate this. So that would be my recommendation. So.
Bob Vinetz, I'm a pediatrician. Looking forward to possible full retirement next June after 45 years of practice. Yes, I have been burned out. Thank you all very much. This has been really a beautiful presentation, and I think your experiences match so many of ours, and your advice so many that we need in healthcare. When I learned about this conference, I sent out the information about it to a colleague of mine, very wise, long experienced colleague. And he wrote me back something I would like to read to you, and I would love your thoughts on this. He said, "I hope this conference really strikes out in new directions. If the problem of physician burnout is so widespread that it requires tons of conferences, meetings, and articles, then the problem must be structural. Attempting to only focus solutions on individual physicians, as if they are the ones individually responsible for fixing the problem, is a mistake. The medical power elite still is not looking at the reasons why the problem is structural. The three main causes, in his view, of physician burnout are workload, workload, and workload." Right. There is a global attempt by many in control of the system to squeeze as much so-called productivity out of workers, including professional workers, as possible. The same problem is well documented in the academy, and I would say in the K through 12 schools. You can substitute the word physician for professor or for teacher. Side by me, I think the medical profession is going the same way as the teaching profession, and it is very, very sad to me. 2 more points. Physician burnout seems directly related to the intrusion of corporate values into the house of medicine. He finally says that achieving single payer as a structural approach could go a long way to reduce physician burnout.
Okay, well, I
agree with that. What I can say is, for me, when I was training in residency, when I was in the clinic, feeling like rushed to see so many patients, it was incredibly stressful. And I wanted to spend more time with each patient, but felt like I have to get out because this patient's waiting and they've booked this patient at this time. So part of what I did to protect myself is I became an inpatient doctor. And so for me, when I'm as a hospitalist, I get consulted by the ER, I can go spend 40 minutes with that patient. And when I'm rounding on the floor, I, in a sense, make my own hours that I can spend as much time as I want with each patient. And for me, that was really calming to me, that I got to do that. And so honestly, that is partly why I became what I've become.
Yeah.
Yeah.
But the system, you had to escape a part of the system that controls the vast majority of us in primary care. And many of us, if not most of us, can't, or for various reasons, don't escape in that way. The system itself, the structure of the system, and the values of profit and so-called productivity in terms of financial consequences is controlling, and it's deadly.
If I may, I think that some of your points that you make are very valid. I think that yeah, that's right. That's right. Firstly, congratulations on your upcoming retirement. I hope to join you in 5 years. But what I was going to say is that I think some of the points that you make are very valid. But I think that there's a couple of other points that I would add on to what you were saying. I think that we cannot, as physicians or healthcare providers, blame the issue with burnout solely on health systems and the non-doctors or the suits. That's not, a part of this is significantly a personal, cultural way that physicians were trained and taught to not care for the caregiver, to not care for themselves, to forego themselves, or from a surgical perspective, that it's a sign of weakness to be burned out. This is a culture that we created, and we're now changing. So part of this is on us. The second part that I would say is that recently, with the understanding of burnout and with some of the evidence that we spoke about, it's become clear to healthcare systems and that it is to their benefit to promote the provider's wellness, hence the quadruple goal and all that stuff. We can say maybe this should have happened earlier or later or whatever, but the point is that it has become clear that it's to the health system's benefit for you to be more balanced. You'll give better patient care that way. And I think that this alignment that has occurred between us and our administrative partners is really enabled us to catalyze this fight. Lastly, I would say that, I think that healthcare systems have really caught up much faster than we give them credit for. And they're really partnering with physicians at a much more rapid phase. I can only speak from our system, and I can say that in our system, we're offering primary care physicians and any physician a variety of different tracks where they can work 8/10 or part-time or have a non-traditional schedule. They can work a half-time schedule. They can change their own schedule because a system like ours is sensitive to the data that shows physicians need to have control over their environment to be better physicians. And in the end, that's what the health system and the doctor want. So I think that this alignment that's happening is a good thing, and it will go a long way to fighting some of the issues that you and your friend so nicely depicted for us.
I agree, and I also think, at UCLA we take physician engagement surveys, and I would say that our administration has been very responsive to those, and like you said, it's a topic that can't be ignored, and I would like to also give our hospital administration a lot of credit for caring about this topic.
If I could just comment back on that. The institutions, and more physicians, most physicians now are employees. Big change from 30, 40 years ago when I started. The organizations for which we work vary from being, insensitive, unresponsive, unenlightened, to those such as Kaiser, which I think, and apparently UCLA and others, are being enlightened and really caring for those who work in their systems. But even those institutions have to respond to the financial and business pressures and of the environment in which those institutions function. It's the environment, the financial environment in which Kaiser and UCLA and Cedars and every other organization has to function, which is so oppressive. We can only, it's like PTSD, I think you mentioned. It would be so much better if a negotiation could be made to avoid the wars in which our soldiers have to fight and suffer PTSD, then spend all of our time, like most of us are doing now here, on figuring out how to deal with the damn problem.
It's a stepwise process, and I think that slowly progress is being made. And as you mentioned, there's always going to be road bumps, but I think that, physicians who are not in systems also burn out. Private practice physicians have a huge rate of burnout. And I just think that, as physicians take more ownership and more leadership, and as institutions figure out that, like ours has, that the end outcome is dependent on having a physician that's not burnt out, I think that this issue will get more attention, and we're going to continue to improve.
My name is Dr. Jessie Sherrod. I'm a pediatric infectious disease specialist, and I'm a victim of the system. My question, actually, I want to commend you on your presentation from your friend, because I think it illuminates some of the major issues that we're facing. I graduated Harvard Medical School in 1975. And during my tenure as a medical student, I thought then that the training was inhumane, even as a medical student. And I actually made the comment to a friend of mine who was in the School of Public Health, who had gone to undergraduate school with me. But I continued because it was an opportunity that rarely occurs for people like me. And so I crashed. My question is along the same lines that you're talking. What's going on at the medical school level to change the process of training? Because sleep deprivation is a form of brainwashing. It's the most common form of brainwashing. And so by the time you finish your internship, your HPA axis has been disrupted, and you're not thinking clearly. I mean, you may be doing the things that you learn robotly, but as far as making decisions about yourself, by that time, you've been brainwashed that the patient is the most important thing and that you have to just forsake yourself and take care of the patients. And my question is, along the lines of his, is that what are we doing at the medical school level to change this process? And I actually think, I know that we have some responsibility for our own health, and we have to take that responsibility, but with the new environment of corporatization of medicine, where everything is based on financial gain, and patients are being treated as parts, and we are, physicians are now technicians, and you're told that you have 7 minutes to see a patient with 5 different problems. I mean, how do you can personally say, okay, I just resign and go home. But how do you deal with that? And I think we have to ask these hard questions and look at what we can do as physicians to actually take back our power, because that has been taken away. And I think the AMA kind of sold us out with the corporatization of medicine. So my question is, what's being done on the structural level to change, because it's getting worse, I think, than it was when I even graduated and I burned out? That's my question.
I'd like to talk to that. And first, thank you so much for sharing that. It's very passionate and beautiful. There is the Mind and Life Institute, which is a big institution that is focusing on anyone doing research in contemplative sciences. And there are a lot of medical schools that go there, and a big pioneering medical school is Brown. And they have implemented mindfulness throughout their entire curriculum. It is so impressive. And you can go on their website, and for first and second year medical students, they have for every module that they do an appropriate mindfulness activity. So during the cadaver lab, they also have mindfulness for death and dying, and all these insightful things. Now, of course, that's new, and this is very forefront leading. Brown University, University of Rochester, University of Virginia School of Nursing has the Compassionate Care Initiative called the CCI, and they're initiating compassionate care throughout their School of Nursing curriculum. So it's one thing to offer elective, it's another thing to have it threaded throughout the curriculum. And I do agree that this is where us as educators, as professionals, need to set examples and get the students, because in 10 years, they're our leaders, and they will be the ones making the system change. I mean, I see a lot of master's students here, and we're trying to teach you how to be the system change, and this is what we're talking about, so that it's not only to the individual. So I do know on the East Coast, there's some schools really pushing for this. Of course, as we know, at least for nursing, the West Coast trickles down a little bit later, but we do get the popular music first, and then it trickles over there. But you know, from a nursing perspective, the West Coast sometimes is a little delayed, but I do think curriculum such as Brown University is something to be really admired. And I know within the School of Nursing here, faculty are starting to get this buzz, and they're starting to realize that we need to do compassion training with our students, like immediately. We need to teach how to deliver bad news. We need to teach these things, and we need to teach self-care, which is not taught, you know. So I really commend your innovation, truly. So that's just one thing that I know. And if anyone's interested, that Mind and Life Institute, every other year they offer these symposiums, which is so inspiring to be around like-minded researchers. It's really nice. So.
I'd like to add two quick points. I like to, I really applaud both of these physicians for bringing these points up. This is not an easy thing to do. It's difficult to go against the culture that we were trained and say, I'm not happy with this, and this is what's been happening. So, and I think that it's not easy to do, and it's hard, and I applaud you for saying it, especially in public. And I think that we listened to physicians such as yourself and tried to change the way we train our next generation. I can only speak from our institution in that we have significant training for new physicians for the first 3 years of their time in our institution, for burnout prevention, for asking for help, and for peer support. And also, in about a year, the first class of the Kaiser Permanente School of Medicine will open in Pasadena. And the entire curriculum is now being built with each aspect of the curriculum having a significant emphasis on burnout prevention, on wellness and well-being, and our wellness leaders are actually building that curriculum. So I just want to let you know that your cries for help have been heard even by the institutions and by the healthcare systems. And it's because of physicians like you that this was noticed. So thank you.
My name is Suzanne. I'm a physician as well in occupational medicine. And this is, I ended up here because of something I started doing. So
could you turn on the mic?
It is on. Oh, okay. So again, Suzanne Sergil, I'm in occupational medicine. And so for many years I was working with workers' compensation insurers. And about 4 years ago I started working on doing medication reviews where there was a lot heavy push by the insurer to speak directly with the physician. So I started, you were calling, putting on, a lot of pressure to get the physician then I started seeing that physicians would, either they didn't want to take the call or they wanted to get paid for the call. So more and more physicians, I want to get paid. So I thought, well, you know what, let's just, looking at it from the side of a physician, I said, let me try to help them out and organize this so that these calls aren't sporadic and that maybe they can get paid for it. So over the past year or so, I started developing a platform to do that. And so then once it's all ready, I go back in and start speaking to physicians again about it. And what I found really interesting was that they weren't really interested in getting paid. They're like, I don't care. I don't want $100. And okay, well, what do you want? And what they really wanted was to not get interrupted during the day, to be able to control their schedule. And so, interestingly enough, when I've gone back and, because I deal a lot with the insurers and the people that support them, and I tell them this, they're somewhat surprised. But one question I have listening to you guys is the question of these programs. They're very extensive. And with Kaiser, it's more controlled. But when it gets to be a private practice physician or a big, UCLA, who is going to pay for something that's so not clear cut? And I mean, I think this does go back to what both of you have been talking about, like corporatization of medicine. So when I started looking at what was physicians' problems, electronic medical records just kept popping up. Like that was, I thought, this is so weird. I mean, long work days? No, it was always electronic medical records. And I spoke to tons of physicians, the same thing. And then since I was kind of looking in that space, I realized it is based on the medical system. The negotiation for these certain things that are cheaper, the power, centralized power, in electronic medical records, the Epic controlling everything. So it sounds a little bit over the top, but I do think that, it's important for physicians to sort of regain control and have more of a voice in the development of the systems that are controlling medical practice. And I don't mean just physicians, I mean all healthcare providers. Anyway, that's just one of the things. And I think there was a question, something about your nursing student. I went back to my 25th medical school reunion, and it was really interesting because we had a lot of conversations. First question, would you tell your kids to be a doctor? Everyone said, well, yeah. But the one thing that I found was, it was crazy, after 25 years, everything that I thought I individually hated about medical school, all of my peers did. And they were all happy, whatever. They were successful physicians. And sometimes you think you're alone, but you're not. And I think that's, having that support and open conversations among your peers can be very helpful to reduce some of the stress of it. Anyway.
Hi, good evening. My name is Lorena. I'm going to flip the coin a little bit. I'm a social worker, so I know burnout. So first of all, thank you all for your presentations. Very, very insightful. I have been doing this work for 7 years. So I guess I'm still new compared to some of my coworkers, my colleagues. But I just got a new position as a program manager, and now I'm supervising staff. And while I can relate to the burnout issue, I also understand that wellness and self-care is part of a structural responsibility. So as a supervisor, as someone who supervises folks who are going through burnout, what would you say, or what would you recommend to myself and anyone else here that we can do, what sort of support we can provide to our staff in order to help them through this burnout that they're experiencing?
I would say that there's a couple things that you can do. One of the main things you can do is to note that you yourself are at more risk for burnout than the people that work for you. We found that supervisory roles such as chiefs of departments and chairmen and stuff like that, and unit leads. I was saying that one of the things we found that those who are in management, in like leadership roles, have a high chance of potentially having burnout. So one of the first things I would say is that for you is to take care of yourself, make sure that you are working on your balance. The second thing I would say is you got to lead by example. And I think that if you lead by example, that sets a culture that it's okay to say when someone is burned out, that it's okay to ask for help, and take it from there.
One of the things I recently did was I went to a week-long conference on emotional intelligence. And believe me, I thought I was emotionally intelligent until I went to the conference. And I learned so much about being a leader and all about context and content and about, I thought I knew about how human beings were different. Boy, did it really open my eyes. So I think one of our big faults in behavioral health and medicine, and maybe Kaiser does it better, is we want people to be leaders because they work hard and because they're industrious, but I think investing in leadership training is so important, and I think Kaiser takes that seriously.
Is it on? Okay. Hi, my name is Richard Lee. I graduated here from the School of Public Health back in 2008. I'm in psychiatry now. I'm applying for fellowship, and I came out here because of the burnout thing is so personal. Like the doctor here said, it really starts at medical school, like from day one, because for me it was just anatomy, dissecting, you know, like what is going on, what am I getting myself involved in, what's going on right now. And there's no training on how to deal with the emotional aspect of dead bodies and body parts and things like that. And Emotional Intelligence was a book that the head of graduate medical education gave me. It was a great gift, and it was such a good book. But I wish I had that book when I started medical training. It would have saved me a lot of conflicts with healthcare providers and nurses and things like that. But I think it really does start really early on. And Dr. Loy, like when you said you remember every patient, you know, it was like a PTSD thing. I mean, right there, like I can remember every patient I ever treated, and if there was a way to kind of process it and be able to sleep at night and be able to function, it would really help me, and I'm sure a lot of my colleagues and friends. And sorry not to leave Dr. Furhar out, but the culture of, you know, medical school is really just that surgical culture is there. It's like, don't show weakness, you know. Weakness is like the worst thing you can possibly show, and not knowing your material, and it's just it's a tough environment, you know. And I was out of state, and I recently moved back, and it's nice to be back in California, but yeah, it really starts early, like very early in medical school, and I'm sure for nursing school and other health professionals too. If the training really started a lot earlier, it would have really helped. Thank you.
I think now we are being so much more open about mental health in our trainees, and people don't have to hide like I think they were forced to before in training. And you know, when we meet with our residents, and I'm an advisor to about 15 residents, and all of the residency advisors, each time we meet with a resident, one of the things that we all talk about is mental health and stress, and talk about the resources that are available to each resident. So we talk about the Behavioral Wellness Center, and we will put fake clinics in their schedule so that they can go, and so that nobody else knows that they're going to see their therapist at the Behavioral Wellness Center, for example. We give them time off. You know, whether it's an hour every Thursday, we are able to make it happen. And I think that's pretty new. I don't think that would have been accepted before, but now it is. So now, you know, we'll have a resident who we know that every Thursday she goes to the Behavioral Wellness Center for an hour, and then she comes back to work, and it's in her schedule, but nobody knows that it's in her schedule. And so I think it is becoming acceptable to talk about it, and we should be talking about it, because we know that this is a really high-risk group for mental health issues. And so I think that is new and changing, and I really you know, acknowledge Dr. Miyoto, talking about the Behavioral Wellness Center and how wonderful it is that it's this free resource to medical students and residents and fellows who are really taking advantage of it. So I think that's different now.
Really grateful to be here tonight. Just want to thank you folks for sharing your stories, and all you folks up there. My name's Hugo Munoz. I'm with oh, she's gone now. I guess I'm the only one in that field here tonight. I hope not. I'm in the social work field, rapid rehousing case manager. I've got a caseload of about 40 folks that are homeless, and the problem's not going to get any easier. But LA County has had it in in them to pour a bunch of money into rapid rehousing, as well via Measure H and as well as Measure Triple H. We're kind of on the cutting edge, but we've also very quickly become kind of the big box service provider in California. I'm with PATH. And one of the things that we're really grappling with is the question of what will the culture look like because of so much money being poured into these services. So I'm really kind of curious to know how, in addition to kind of leading by example and coming to these conferences, how I can help my colleagues prevent burnout. That's really one of the reasons why I'm here. But also really grateful that I'm here on their dime. So I don't know if you can speak to that. I've got plenty of colleagues that are like, nope, don't have time for training. Don't have time for training. I've got, my caseload is about 40 people. And so, yeah, if you can speak to that, I'd really greatly appreciate that. Thank you.
So I think that there's a couple of things to say. And I would say that thank you for all the work that you do as a physician with inpatients and outpatients and homeless patients. I would say that it would be much more difficult for me to do what I do without people like you. So thank you. The second thing I would say is that there are two things that I think are very important. One is setting limits. And I think, it may be detrimental in the short term to set limits. You may have to leave a case for the next day or something like that. But in the long term, setting your limits and setting your boundaries are very important for you. Something that as an altruistic field, we're not trained to usually do, but we are trying to change that. That's one. The second thing I would say is that it goes back to your own balance of challenges versus resources. Every single person who has asked the question tonight has had a different challenge versus resource imbalance, right? They're all different. Every single one of us has different challenges that affect our ability to be sort of happy with our wellness. And that's sort of goes to the point in that you're going to have to look at yourself, at your own specific challenges, beyond that of being a case manager, but also look at what your resources are, whether it's your peer support, whether it's support from your spouse, whether it's support from your institution, or whether it's going for a run every day. I mean, I don't know. It depends on what yours are. And the key is that every single person will find that balance differently and through different resources. So I can't give you a single magic silver bullet. But we can tell you that if you work on your resources versus your challenges, you will eventually find that balance. And it will change every day, and you have to keep on working on it. It's like the practice of medicine, or the practice of being a case manager. I think that's the best.
I also, in my own trajectory on this path, I would be the person that would send the burnout article around, or ask if people wanted to talk about well-being. And people used to laugh at me and say that was my hobby.
Wow.
But by pushing the agenda in the group, pretty soon people would say, oh, let's go talk to Karen, I've got an idea about that. So you really can be that light in an informal way, and then when the time's right, sometimes it takes off, or your colleagues say, hey, what do you think? I got this challenge.
Thank you.
Thank you for this great panel. I'm Jeffrey Ring. I'm a health psychologist, and I work in this realm of physician vitality. And I was meeting with a group of residents at a very big, important hospital recently, and I asked them, when you look at your faculty, who really stands out for you as a role model of someone who really is doing it in terms of life-work balance? And it was silent for a really long time. And then one resident raises her hand and says, there is a faculty member who is amazing in palliative care and works with families with such compassion. And I said, well, that's great, but that's not the answer to my question. Like, it's not about wellness. So the good news is that the ACGME, the Accreditation Council for Graduate Medical Education, says now that it is incumbent upon residencies to do and document wellness for residents, but also for faculty. So my question is, do you have plans for One, sort of overall faculty wellness for those crispy and challenging faculty around. And then second, do you see any importance or value or plans for sort of targeting wellness for minority physicians and gay and lesbian physicians, special populations of physicians who carry all of the burdens we've talked about tonight, but also burdens of racism and sexism and heterosexism and so forth. So I'm just curious about that realm of intervention.
Well, I would say that I think. Sorry, this was a good excuse to get out of this one. I think that to your first question, I believe that institutions like UCLA, like Cedars, and some of the many other institutions like the Mayo and Stanford, Minnesota, they've really taken the lead, and even Kaiser, we've really taken the lead in trying to reach out to those sort of, as you said, crispy older faculty. And I too, when I first started doing this, I would ask some of those faculties to come to an event, and they would give me an answer like, well, instead of doing this, why can't I have more vacation? Something, something harsh. And that culture has actually changed drastically in the past 3 or 4 years of doing this. So even the most resistant of physicians, we all have the same basic need. And eventually, I think that if enough opportunity is provided, you will reach those physicians. It took me a couple years, but it's happening. With regards to reaching different minority and different groups, I think that's a very, very valid point. I think it's an area of great need. And I think it's an area that we're going to try to develop. We have been working towards reaching women in medicine because there was data showing that there was a higher rate of burnout in women physicians as well. So we have developed that. With regards to reaching other impacted groups, I think that's a great area of work that I hope to be able to come back the next year or two and give you more information and more development on. But it is something that we have to work on.
So Barbara had a slide about the top departments with greatest doctor burnout. And they were ED, OBGYN, internal medicine, and family medicine. So my question was if the disease burden shifting to more chronic disease heavy, if that contributes to physician burnout, and also what's the possible impact of addressing the population's social determinants of health on mitigating physician burnout.
I think we have a long way to go because we really do practice sick care, not health care. And we're hoping with our technologies that we actually are looking at health care for the future. I think the specialties you discussed often will tell you that they're the most time constrained. And so technology has to improve. We have to, I talked to the dean of the Dell Medical School, and they said they're working on voice recognition technology so the provider and the patient walk in the room and the whole thing's recorded and you shake hands at the end. So I think we need to make those time-compressed specialties more manageable. But I'm not sure that answers your questions.
We have one more question.
Can you hear me?
Yes.
I'm Ellen. I'm a nurse and I'm also an MPH student. And just to represent the nurses, I have a nursing directed question or related question. I feel like among nurses, in terms of the source of the burnout, it's pretty obvious that it's understaffing having too high of a patient load per shift. And I feel like, it said like something like 1 out of 3 nurses say that, but I don't know a single nurse who wouldn't say that about where they work. Maybe I just haven't worked in the best places. But given that that's like a pretty clear determinant of nursing burnout, I'm wondering if you guys have found that there's very much being done about that. I mean, telling people to do mindfulness training and stuff is really very valuable, but honestly, it's almost like a private joke among, when somebody comes to the floor and says like, oh, you just need to take some time for yourself, we're all like, okay, yeah, I'll do that if you take my patients, or like on my 5-minute break, I'll go meditate somewhere, or, it's not a realistic recommendation, unfortunately, for the kinds of units that we work on. So given that staffing is like just a really obvious answer, is there anything being done? Is there enough being done about it? And if not, what do you guys see as the barriers to that happening?
I think I'd like to speak to that. So as any health executive person in here can speak to, it is a very difficult problem to solve for a lot of reasons. One, the areas where the highest burnout are ICUs, ERs, et cetera, have the highest turnover. And that is usually not the positions where you hire new graduates. Now, recently, new graduates have been hired into the ICUs, and it is a long training, and still EDs, a Trauma 1 level center, will not hire a new graduate for safety purposes. So now let's take a hospital that is not in a large metropolitan area such as Lancaster. And Antelope Valley Hospital is the 4th busiest hospital in all of California and gets more trauma than we can even imagine. Yet all the nurses usually live in Lancaster. So now if you're short-staffed, where do you call the people in? Where is there to get people? There are no nurses available. You can't float a pediatric nurse, or maybe that could help, but that doesn't help the high trauma and help these things, So what seems like a very simple solution is not. Now, let's go even more systematic. We need to get more nurses through nursing schools is what we need. Now, why can't we? Well, we can't find enough faculty. We can't get enough funding. Now it's a system problem, right? It's not just a let's solve the unit. Now, wealthy hospitals, or hospitals well-directed, can have an in-house float pool or an in-house resource team, right? But this is why I think it's so important our nursing students go to other hospitals, because they think everybody's like Ronald Reagan. I'm sorry, everybody doesn't have a private room, okay? In most hospitals, the supply room should have like a classical music song to it in Ronald Reagan. It's just phenomenal, And that is not the usual experience. So it's very interesting. The system is very difficult with this, So, it might even go back to nursing schools, I think. So, yeah, please.
Sorry, so I didn't phrase it right. It's not, it's a patient-to-nurse ratio. It's about a patient-to-nurse ratio, sorry, I wasn't referring to like the nursing shortage. Where I've worked, there are like plenty of people who want to be nurses at those hospitals, but they refuse to hire enough nurses to staff the floor in a way that the nurses feel is safe. Okay,
but this is where I'm going to get on the nursing profession, and that we don't have enough political advocacy from nurses. So this is where, because I don't want to be a politician, so this is where I'm hoping one of you will. But in California, we have a lot of political advocacy in nursing where we've gotten a ratio of 1 to 4. Okay, now when I worked in New York, there was no ratio. So I would have 14 patients in the ER and 4 would be on ventilators, easily. So that's why sometimes when I come to California, nurses whine, I'm like, listen, honey, So it's interesting, and this is where I think we actually need legislation and political activism and our public health and these type of things to go to Sacramento to do these things, so that then our executives have support, legislative support, in order to make these changes. So we can ask, our managers and advisors to do things, but sometimes things can't be mandated until they become legal aspects. So this is also where we need to do research. Does a lower staff ratio decrease medical errors, decrease these things? And then we can come with the data to show this. So why we're very lucky, we have nursing research, but this is a PhD in nursing is very young as well. We're still trying to validate the science of nursing if you really think about it. So good for you getting your master's. Well done. Yeah, well done. Very good.
Okay, I know that we still have a few people asking questions, but we've arrived at our midnight hour, or our end of the. I'm not good at this, so excuse me. So yes, we've reached the end of our program tonight. I'm sure some of our panelists might be willing to pay a little extra to answer any last-minute questions. Please join me in thanking our moderator and our speakers tonight. Thank you to all of you for coming out tonight and our people who are joining us through live stream. Our next health forum, we're taking, of course, December off. We'll be back on January 31st. So please look out for your emails leading up to the end of the month of January. Thank you again. Happy holidays to all of you.